Good evening, everybody, and welcome to the 36th edition of the Amasi online series. It's been a full 3 years since we've been holding this program on the first or second Thursday of every month. And we have a very eminent speaker today with us who will be taking us through the complexities of multi-compartment prolapse. To start the program, I invite Dr. Kalpesh Jani, the president of our association, for his introductory remarks.
Yeah, good evening, everybody. So again, it's Thursday time. It's a day that we look forward with great anticipation in Amasi because we get the top speakers in the field to speak about their areas of expertise. And today is no exception, as we are going to talk about a topic which is not often discussed in Amasi Fora. Though do we just show a Typically, we show a surgery, a laparoscopic ventral rectopexy or a posterior mesh rectopexy and do away with the prolapse thing. But as you'll realize after this talk that it's a much more complex problem and requires a tailored approach, a logical approach, and it's not a single thing. And it can be an anterior compartment, posterior compartment, to go into all the details of this disease and how to manage this disease. We are going to have a unique perspective from our one of the world leaders, world authorities on this subject. That's Professor Gabriele Naldini. And to introduce him and the moderators, I'll hand it over to Rajdeep and Dr. Jayanta Das. Rajdeep, over to you.
Thank you very much, Dr. Kalpesh. Dr. Gabriele Naldini. He's a senior consultant at the Colorectal Surgery Unit, Humanitas Research Hospital, Milan, a consultant at the San Rosare Private Hospital, Pisa, Villa Donatella Private Hospital in Florence, Director of Proctology and Pelvic Floor, School of Italian Society of Surgery, founder of Proctology and Pelvic Floor Multidisciplinary Clinic Center at the University Hospital of Pisa, the Director of Proctology and Perineal Surgical Unit at University Hospital of Pisa, co-director of proctology pelvic floor at the Italian Spanish Turkish School, a teacher and a pelvic floor master at the Pisa University, Rome Sapienza University, Rome Tor Vergata University, and the Naples University. And he is also a teacher at the ERCAT Strasbourg Proctology and Colorectal course. But his extracurricular activities include sports. He has been on the Italian national swimming team also. He continues his love for sports and is really dedicated to his family. He has been focusing his efforts since the past 15 years on the complex pathologies of the pelvic floor, and he has developed an integrated multidisciplinary approach. And we were just talking about the standardization which is required in these procedures to get a good result. Multi-compartment prolapse, a very vexing and a complex problem. Everybody does it in his own way, but we'll see what the correct way to approach these problems are. And for that, Gabriele Naldini will be talking in detail about these. I invite Dr. Jayanta Das. He's the chairman of the East Zone to introduce the moderators for today's session. Dr. Jayanta, please.
Thank you, sir. Good evening to all. Today there will be a discussion on a very good and complex topic as said by Dr. Kalpesh and Dr. Rajdeep. So to moderate this session, we have three very eminent surgeons from the different part of India. That is from West India, we have Dr. Rai Patankar, an eminent surgeon. From South India, we have Dr. Prakash Kurumbar from Aster Medicity Hospital, Kochi. And from East India, from Bhubaneswar, we have Dr. Pankaj Kumar, who has undergone training under Professor Gabriele Nandini recently. So I would hand over the session to the moderators. Over to you, Dr. Pankaj.
Sir. So without wasting this time, I'll tell you one thing about Dr. Gabriele. So although Dr. Gabriele had numerous articles on the pelvic floor, what truly sets him apart is the intellectual rigor. He never accepts a problem at the face value. He constantly asks why a condition behave in this way, why we should be following the traditional method, why we should not be following the traditional method. So that has actually changing the management part. So I have learned a lot of things from him. And the way I treat the patient, it all because of his advice. So now I think I should not waste time and hand over to Dr. Putta. Dr. Roy.
Yes, it is my privilege to welcome Dr. Gabriel. And truly, there are more questions than answers in this problem of multi-compartment prolapse. I don't think there is a gold standard and we don't have the final answer. And we are looking forward to hearing from you, Dr. Gabriel. Could you share your slides, please?
I want not the screen.
Yes.
Okay. Okay.
Yes, we can see it.
Okay, you can see?
Yeah, we can see.
We can hear you and we can see you. Please go ahead.
Okay. Okay, thank you very much. This is incredible for me to hear this kind of comment of my work, and so I'm very happy to be here with you. So, but we will move on with this topic. Sorry, I need to. Okay. I'm not conflict of interest. Why we talk about multi-compartmental problem? We talk about that because we have, sorry, just a minute. Because the number of patients that have a multi-compartment disease is growing day by day. We know that in the next future, we will have a lot of these patients that will have this kind of problem. And more, sorry. And multi-compartment pelvic floor disease is an extremely challenging topic. There are no guidelines. Unfortunately, it still seems that there is a urogynecology pelvic floor and a colorectal pelvic floor. But for example, there is still a lot of confusion among colorectal surgeons, highlighting this recent international consensus which is recently published and where I participate on. Of the 27 consensus statements, 11% were supported by moderate evidence, 66% by low or very low quality evidence, and 22% are expert opinion. So it means that there is not a consensus. This is only personal opinion. A lot of surgeons, but it's only personal opinion or expert opinion because the evidence are very low. Message from colorectal literature show that the rectocele internal rectal prolapse and the external rectal prolapse appear to be isolated anatomical and symptomatic pathologies and are rarely associated with anatomical and symptomatic pathology of the middle and anterior compartment. And that is not true because there are some important papers that show that we can have more than 50% of associated disorders. This is, for example, my experience, robotic rectopexy, single center experience. From 2014-2023, we have 190 patients that were operated with robotic rectopexy, 98 for internal rectal prolapse, and 92 for external rectal prolapse. And what we see is that the association between ventriculotomy and a procedure for the correction of a middle or anterior compartment, posterior and or anterior colpopractosacropexy, or with or without a supracervical hysterectomy, is 22% for external rectal prolapse, but 77% for internal rectal prolapse. Why? Probably because my first indication for abdominal approaches is a multi-compartment disease. And don't do that is a big mistake if you don't go to analyze all the pelvis. PFD requires a working in a multidisciplinary team, having an open mind to unify the language because we need to have, we can't say this is a retocele, no, for the gynecologist, this is a colpocele, no, this is a cystocele. No, we need to unify the language and develop diagnostic and therapeutic pathway. I will try to share some of my experience from 15 years of work in a multidisciplinary team. Assessment must always begin with a precise analysis of symptoms. It is a benign functional disease, and our task is to improve the patient's quality of life. It's not to correct the anatomy. We need to correct the anatomy if we want to correct the symptoms. Often, completely different symptoms can correspond to the same anatomical situation. So where we start? We start from patient interview. Remember, it is a benign disease. We have only to solve the symptom of the patients. Okay, we start from them, and then we have a physical examination. In my opinion, after that, if you are experienced, you have 80 to 90% of the needed information. With other tests that we do to finalize the treatment proposed, for example, we can do urodynamic studies, but what we know is that the possible information that we can have from this kind of assessment is occult stress, urinary incontinence detection, predictive value for voiding dysfunction, persistence, or resolution, predictive value for overactive bladder symptom, persistent or resolution. So another thing that we can have is to have some address if we prefer to do if we need to do a sacral suspension, a posterior suspension, or a lateral suspension. This is colposacropexy. This is a lateral suspension. You can see that the difference is that the uterus in the lateral suspension remain in the middle of the pelvic. If you do a sacral suspension, the vagina in the uterus is tractionated to the sacral promontory. But are not two possibilities. They have different indication. If we have apical or anterior defect, we can do lateral suspension. If we have apical and posterior or three-compartmental disease, we can do sacral suspension. But this is information are really the information that we showed before about the urodynamic test are really leads to a change in the management of type of surgical procedure. There is no evidence that the outcome of surgery is altered by prior UDS. And what about radiological imaging, defecography, fecal MRI, ecodefecography? In my opinion, it is important to see the dynamic phase to better understand of the defecation, to better understand the problem. Defecography is better because it analyzes even the defecation phase. The fecal MRI include the valsalva and sometimes a partial defecation. And also the ecodefecography include only valsalva, and valsalva is not like a defecation. So in conclusion, in my opinion, enterodefecatory is better for obstructed defecation in absence or other problem of the pelvic floor. The fecal MRI is better in presence of multi-compartment defects already highlighted by the medical history and examination. And ecodefecography is simple. We can do it ourselves and allow to clearly see all the defect, but the expulsive phase is missing. This is the real problem because we understand really the problem of the prolapse when you have the expulsion of feces. Another test is a neonatal manometry, always necessary to guide treatment only if the clinical and amnestic evaluation suggests an isolated functional problem or a functional problem associated with an anatomical one. In this case, preoperative or better postoperative rehabilitation can be considered. if we have anatomical problems with also functional problem, what we prefer to do is doing first the surgical correction and the secondary the pelvic floor rehabilitation, because in this way you can rehabilitate the new anatomy, because it's unuseful to rehabilitate the old anatomy. The test can be helpful to decide the type of surgical approach, abdominal, transanal, transperineal, and to decide the quantification of the problem. Not all prolapse are the same. Not all the vaginal prolapse are the same. So we need to decide with this test how much and where to suspend, how to correct middle and anterior problems, how much to resect from below, how much application of the rectum from below, how much and where make the traction from above. But finally, who to operate? This is the main question. But it's simple, or must be simple. The patients in whom the symptoms can be correlated with the anatomical defect demonstrated by objective examination and instrumental examination. Why? Because functional surgery doesn't exist. We can only try to restore the normal anatomy and hope that the new normal anatomy can give a functional improvement. Yes, when we have a constipation, what we can do? We can pull up the rectum and fix them to something with something, stitches or mesh. We can cut the rectum in excess, Starr-Altmaier. We can make application on the rectum, Delorme, internal or external Delorme. We can try to neuromodulate the sacral nerve. Okay, this is what we can do. We call it functional surgery, but what we can make is only an anatomical correction. And we are far from saying that we restore the normal anatomy. We can restore probably a normal position. We can reduce in a different way the dimension and change the elasticity of the rectum. We can try to improve the performance of the rectum with sacral nerve neuromodulation, but mesh are not ligaments or fascia. The upper portion of the rectum is not like ampulla. A prolapsed rectum that is repositioned and suspended in the abdomen will never have the same functionality of a normal rectum. And the applicated rectum can't have the same functionality of a normal rectum. So, after 10 years of work on this topic, we published this complex pelvic organ prolapse decision-making algorithm. This algorithm put together when we have associated disease, and I'm going to analyze step by step. So first, we do not start doing test or planning operation before having normalized the quality of consistency of stool. Me too, if I have a type 1 or type 2 of Bristol scale stool, probably I am constipated. Okay, and if I have a type 6 or type 7, I could be incontinent. So first we have to normalize the consistency of stool. Then pelvic floor rehabilitation, in my opinion, not mandatory before surgery. Is a fake that we have in literature that we can do surgery only after the failure of pelvic floor rehabilitation. In my opinion, I believe absolutely in pelvic floor rehabilitation, but I need to have a pelvic floor functional problem before to give the indication. And for example, in this paper, in this consensus that we wrote, the aims is to restore the abdominopelvic coordination, sphincter motor function, and they give a good rectal sensitivity. But PFR is reserved for selected patients in whom there is a specific indication and when conventional medical treatment, drug, fibers, diet has failed. So you see that that is a complex decision-making algorithm. But as we pointed out in our paper on the decision-making algorithm about pelvic organ prolapse, being a pathology with patients, symptoms, anatomical situation very heterogeneous, who does only one type of operation thinking that is miraculous, will be a loser. My selection criteria are influenced mainly by the availability of alternative. If I'm able to do good pelvic floor rehabilitation, ventriculotopexic, colpoproctosarcopexy, colposacropexy, popliteral suspension, internal delon, STAR, transvaginal transperineal levatorplasty, levator ani lesion repair, sacral nerve neuromodulation, probably my indication will be more precise. It is obvious that if I treat obstructed defecation with just one or two operations, I don't have much need for differential dialysis. This is Lapalissiano. This is from Lapalis. This is obvious. Okay. So we start from my decision making. So when we have an internal rectal prolapse, okay, with a lambda rectocele, lambda means a supraperineal rectocele, not a high rectocele, but a supraperineal with symptom of defecation incomplete fragment associated with hemorrhoidal prolapse or digitation or perineal manipulation. What we can do, this is a patient that is not possible to treat through the abdomen, this very low rectocele. In this case, we can do a STAR procedure. But more important that the indication for STAR is important, the contraindication for STAR. Any symptom of impaired anal continence, manometric ultrasound find that reveal weak sphincter or precarious continence balance, anal stenosis, unsatisfactory defecation. Take care about this concept, that is unsatisfactory defecation. There are especially women, now also some men, but especially women that have not a really obstructed defecation, but because they would like to go to the toilet when they want, how they want, in the moment that they want, and the constant must be as they want. So they want to be able to go out and to be ready for a G8 or for a meeting with Brad Pitt. So this is a really difficult, really dangerous patient because it is not a real obstructed defecation, but is an unsatisfactory defecation. IBS and proctitis are contraindication. This is the STAR procedure. You see that I don't start the procedure without a valve suspending the anterior wall of the posterior wall of the vagina. Now I'm doing with a single stapler, with a high volume stick-on stapler. We start with stitch at 1. It's natural that I decide the level of the first stitch on the level of the traction, depending of the length of the prolapse. So I start at 1, 11, then 5. You see that the stitch must be very superficial. It's not true that you need to go deep and deep, because we need to resect a lot of mucosa, less muscular and very few fat, because most of the time we have also the fat. So 1, 11, 5, 7, 3, 9. At this time, you put together, and this is the target of our resection. We put the stapler. You see that with this stapler is a high volume, with barrier free, and with this mega window that allow to control what you are doing, what you are resecting. This is not more a blind surgery. In this way, you can manage putting the finger on the traction. You can manage always to check the vagina. Rectovaginal fistula is not a complication of the operation, it is a complication of the surgeon. If you are not able to do that, it's better if you don't do. And you see that this is the the resected specimen. With the same indication on the S due to internal rectal prolapse with lambda rectocele, but if there is the association also with impaired continence, what we do is internal Delon. Why we do that? Because to resect the rectum with star in a patient with weak sphincter with difficult balance of the continence, it could be real dangerous. In this way, we start the application at the apex of the muscular layer, at the apex of internal sphincter. In this way, we have an enlargement of the functional anal canal. And we publish that we have very good results both for obstructed defecation, are good, but are not as good as STAR procedure. But we have no incontinence, and we have more than 60% of patients that have an improvement of continence. You see that is a very beautiful procedure because it's very elegant. We have to follow this plane, okay? And we have to push the mucosectomy till when we started to see the umbilication of the muscular layer. Okay. And then we do the application of the muscular layer. We start with the 4 cardinal stitch, 12 is mucosa, muscular, mucosa. Then at 3, the same, you can see all the muscular wall of the rectum. Then you do the traction, you look for the mucosa and give the last stitch on the mucosa. And then we put some stitch between the first 4 stitches, always involving the muscular layer, and with 8 stitches. Okay. And then we put some stitch only mucosa. I can move to other. You see that the level of the suture is the same as a STAR, okay, at the apex of hemorrhoidal tissue. This is the only landmark that we have to take in consideration, the apex of hemorrhoidal tissue. We move. Remember that don't do STAR if we have a mesh in the dome, because STAR is retalization. If we have adhesions, we can have a very serious problem. But we can have a complication also after the ROM, not only after a STAR. So is another operation that needs to be made with very carefully, with great experience. Then the other problem is the unsatisfactory defecation due to the lack of a guillotine effect of puborectal muscle for finalization of defecation. What it means? When I have the feces, at the end, I need to squeeze to cut the feces. And you have the patients that say, I am not able to finalize. Is because the puborectalis muscle is broken. So this is what we can do. This is an operation that I'm doing now. This is made by the master of this operation, that Professor Bruno Roche, that made in my hospital during one of the last course that I did. So you see that the broken on the puborectalis muscle, and with Vicryl 0, he he closed the hole in the muscle, and he restored the continuity of the muscle. In this case, he's trying to arrive close to the pubis. And in this way, we can have, again, not when you have a broken, this is what you do, because if one leg is broken, when you suspend, this is what to do. Now we do this, okay, again, and he can cut the feces and finalize, and this is useful both for finalization of defecation and for incontinence. I move on. He did bilaterally. And then he closed also the perineal body. Okay, when we have ODS without major anatomical defect, with or without imparaanal continence, what we can do is sacral nerve neuromodulation. I think that everybody have experience of sacral nerve neuromodulation. I don't know if you do. In Italy we do a lot, not so much because economical problem that we have. This is a Seldinger technique. You see that at this level, probably I am not in the right space. I'm not in S3, I am in S2, and I don't have a good bellow. Now I put, and you see that I have a very good bellow in this position. Then I put the needle for the Seldinger procedure, and then always under X-ray control, we put the needle, the stimulator. This is the time lead. Okay. Always check with the X-ray the right position, because it's a one-shot technique. If you see that this is very well positioned, and then we can pass to the subcutaneous part. So now we go to another field, that is internal rectal prolapse with L-rectocele or high rectocele, or external rectal prolapse, especially if associated with enterocele or vaginal posterior wall prolapse, with or without imparaanal continence. What we do is ventriculotomy with or without vaginal wall suspension. Why? I changed this for internal rectal prolapse. I divide the indication for abdominal approach or for transanal approach, because for abdominal approach, also in this paper, that is very important, the internal rectal prolapse ODS symptoms show the least satisfaction. That is is around 68% of satisfaction. This is the procedure. I am happy that we can do robotically. Okay, very good vision. We have to prepare very well the field. We need to have the promontory absolutely free from everything to be able to go directly on the promontory just before that it starts to go down in the pelvis. This is the best way to open, avoiding to have a lesion of vessel lesion, but we have to arrive on the fascia. You see that we leave the right ureter outside. Then we start to open the peritoneum and we start to do a tunnel. You see the nerves very well. Okay. And then we use, this is really, really useful, to put a spatula to suspend the neck of the uterus and the anterior wall of the vagina, together with the traction of the helper on the rectum. And we start with the inverted J incision of the. Remember that on the right side we have only to prepare a tunnel, not to do a posterior dissection. Then you see that in this dissection is a blinded dissection. We have only to cut just a bit or to burn just a little bit, and then we can do a blind dissection. And what I suggest is to stay close to the vagina. This is the vagina. You can see very well the vagina. Why you have to need to stay close to the rectum? And then we see, probably I am arrived. I am close to perineal body. There is something white. That's not true. That's not true. We have other 3-4 centimeters, and we have to try to arrive as deep as is possible. But remember, you can arrive like this. If we open here, we have external sphincter. But now you put the stitch, and after the operation, when you put the finger, the supraperineal rectocele is not possible to correct through the abdomen. This is the biggest advantage of the robotic system, that is the stitch. The possibility to put stitches not where you are able to put, but put stitches where you want to put. And take care about one thing, that what I'm doing is to take a small bite on the mesh, a good bite, a big bite on the rectum, and then I go out close to the first to the where I enters. In this way, avoiding the shrinkage, the wrinkle of the mesh. I think that this is a functional surgery, and the most accurate you are, the better will be your results. You see that with Da Vinci you have a frontal field, and you can work like you are on your table. You can work properly in an easy way. And what we have is high quality results. I can see the mesh that are suspended or wrinkled, and this is something that can increase the possibility to have mesh erosion. We use a 3-0 PDS, 7 or 9 stitch. It depends. Usually we do this. If we have a high intussusception, we can put 2 stitch also intraperitoneal to suspend the rectum intraperitoneally. Then we put always stitch also on the promontory. You see that we needed to feel that is a strong involvement of the fascia of the promontory, and I use Prolene non-absorbable stitches. Okay, we are used to put 2 or 3 stitches. Okay, at the end we have only to close the peritoneum. I can move. Another thing that we can do is this kind of modification if we have associated with high grade of vaginal wall prolapse or cystocele, or high grade of rectocele or anterior rectocele. Now I show the different technique. So which is the advantage of this technique? Modulate 2 different tension because it's a folded mesh. I will show you soon. We have a rectovaginal septum reinforcement. We can maintain the sliding between the rectal and the vaginal wall because we don't put the stitch that involve vagina, mesh, rectum together, because especially during intercourse, we can have a pain during the intercourse for these stitches. and to improve the traction distribution. So we did a ventriculotomy. Okay, now we folded the mesh and we suspended the posterior wall of the vagina. This is a posterior vaginal rectopexy. Okay, is the same concept of the ventriculotomy on the posterior wall of the vagina. The difference is that we have less tension, because this is what we learn from the gyne, that the tension of the vagina must be less than the tension on the rectum. It is important to understand very well the apex of the vagina. This is a young woman, and this is the place where there is the penis that go during the intercourse. And in this way, we can have different tension of the two organs. Okay, you see that this is much more floppy than the other, and that's the finish. But what we do if we have external rectal prolapse? External rectal prolapse that is more than 10 centimeters. If it is less than 10 centimeters, what we used to do is ventriculotomy. If it is 10 centimeters, and especially if we have a severe constipation, what we do is Altmaier procedure. This is too big and too heavy to be suspended, in my opinion. So what we do is, because, for example, in this case was a girl that was operated on a ventriculotomy for external rectal prolapse. And you see that when we open the first cylinder of the rectum, we have more or less 1.5 meter of sigmoid rectum and sigmoid. This is a left hemicolectomy. Okay. And also another thing to do, because we speak about rectal prolapse, but this is something where we have to discuss a lot about, that any prolapse is different from the other. These are all rectal prolapse, but probably one is more challenging of the other. We can't treat with the same operation all these kind of prolapse. This is a Altmaier procedure. You see that it is a recurrence after star procedure. You see the level of the anastomosis of a previous star is completely is a big mistake. They do this taper 5 centimeters to the apex of the hemorrhoidal tissue. Remember that the reference is the apex of the hemorrhoidal tissue. I open the first cylinder, and it is very useful to have the Lone Star. Is Lone Star with Lone Star or without Lone Star is not the same operation. With Lone Star, you can see very well what we are doing. Now, this is the Holy Plane made by downstairs. You see that here we are close to the vagina. We have to check the vagina always, and to separate the vagina from the rectum. And now we push the liberation from the pelvic floor, from the puborectalis muscle. Then we open the peritoneum, and this is the boring part where we have to resect, to prepare resect the rectum. Take care about the hemostasis. What you see that I am very, when I do the hemostasis, I try to stay very far from the mesentery, because if you have a bleeding and the vessel comes into abdomen, could be really dangerous. So you can stay very close to the rectum and not close to the vessel. Then we decide the level of the resection. I move on. And now Now I want to show this part. Okay, this is the post-anal repair. What we do? Okay, we prefer to do a post-anal repair than an anterior levatorplasty. You see that is much more satisfying. Okay, then we go to do the resection, and we are used to do a hands-on anastomosis. Nervous taper. Okay. What we do when we have external rectal prolapse less than 10 centimeters with high-risk patients, young patients with small prolapse, or patients who do not have anus at recti prolapse, what we do is external delorme. This is the external delorme. You see that here we don't have the version. Is not is a rectal prolapse, is not a anus et recti prolapse, because there is not the eversion of the dentate line. This is the mucosectomy. It's a very beautiful procedure. And then you can see very well the muscular layer, and you can put the stitch on the muscular layer. Okay. What we can do when we have a vaginal wall prolapse is ventriculotopecy plus colposacropexy. Okay, some stitch on the apex, then we folded the mesh and we suspended the anterior wall of the vagina. In this way, you can correct also the cystocele. And then we start, now we move faster. Is the abdominal lateral suspension. I showed this video, that is the last one, and then we can start to have the discussion. You see, we put uterine manipulator, and then we push, and then we put a spatula in the vagina. Okay, this is really important to be able to open properly the rectovagina, the vagina bladder space. Then we started to open the lateral ill tunnel from one side and the other side. And then we go as deep as is possible under the trigonus. You see that now we are close to the trigonus. Okay. At this time, we suspend the peritoneum, and we put this mesh. Okay. We fix the mesh under to the vagina under the bladder. Okay. We fix to the neck of the uterus. Then we take the two arms. You see this from the iliac left and right space. We do a tunnel under the peritoneum. And then we make the traction from one side, the same on the other side. And this is the final view. You see that it is completely suspended in the abdomen. Now we move, and I want to finish with this. I think that you have realized that we have a lot of work to do, but it must be done in a multidisciplinary teams. This is really important. Thank you very much.
Great talk, Dr. Gabriel. We really enjoyed that. Any questions from my colleagues, Dr. Prakash, Dr. Rajdeep, Dr. Jayanta, Kalpesh?
Thank you, Professor. It is a wonderful talk. Many of these patients get diagnosed to have psychiatric problems or already on psychiatric medicines. So how important is your preoperative assessment and your counseling, and how do you include them in the preoperative assessment?
It's natural that if we have to consider that the psychiatric problem are due to our the problem that comes before these prolapse, we have to take in consideration that we are going to operate this psychiatric patient, but most of the patients that have a psychiatric problem that focus their problem on the pelvic floor is due because they have a really problem. They can't go out because they have every time the necessity to go to the toilet. So we have to consider also everybody when we get up in the morning, probably our day, we know how we go our day from how we are able to go to the toilet. If I want to go to the toilet, I get up and I'm not able to go, it's normal that my brain will be not free to live my normal life.
Dr. Gabriel, another question on ventral rectopexy. Is there any situation where you would divide one of the two lateral ligaments?
No. Sometimes we involve the ligament. We do we close the ligament to reinforce, say, if we have a very weak pelvic floor. We use also the ligament to increase, but I don't think that we need to cut. You
And
have
a
a
patient with
cut the ligament. You need sometimes the necessity.
So we've seen the St. Mark's group dividing one right lateral ligament and the left lateral ligament, sometimes
Why?
in very deep pouch. If there's a very deep pouch, we don't get access to go up to the endopelvic fascia on both sides. Have you ever felt the need? And is there a variation in technique whether the patient has obstructive defecation versus only a full thickness rectal prolapse, or the same technique?
Oh, no, it's the same indication, same technique, same technique. It's not there is no a way to suspend the external rectal prolapse or the internal rectal prolapse. There is not two different.
Are there any conditions you would use an L-shaped mesh suture to both the levator ani to pull up the pelvic floor?
I don't understand. Sorry.
In some patients, when there is a big pelvic floor descent, we
Yes.
use a L-shaped mesh. And one limb of the L goes on the left levator, the other goes on the right levator, and the proximal part on the sacral promontory. Does that have logic?
It looks logic. It looks logic, but I have no an answer about the descent pelvic floor. I don't think that we have at the moment any kind of procedure that we can solve that. It's not only to pulling up the rectum anterior or posterior that we can reduce the movement of the pelvis when it is weak. We at the moment, if you make an examination to me and say what you can do for pelvic floor the Shan syndrome, I don't know.
So we have been doing a trial comparing two arms, one with pelvic floor, one only doing ventral rectopexy. And we published a preliminary data showing the L-shaped mesh is probably better than a straight mesh.
Wow, this is a good news. I would like to see your technique. So I probably I have one possibility more than what I'm used to do.
Any conditions where you would use a biological mesh in a young sexually active lady?
Only if there is association with inflammatory bowel disease is the only one, because in my experience with biologic mesh, I have much more recurrence than with the other mesh.
So we have seen some dyspareunia, sexual problems after lightweight polypropylene meshes in young women. Have you seen that?
Uh, very few is for that I recommend to do. You see the how we try to distend very well the mesh to reduce the number of stitch, to don't do a lot of traction, but don't do floppy, because if you do floppy, probably you have more possibility to have a problem posterior, and especially this is the problem of indication. Pelvic floor pain, or also the sensation of heaviness, is not always a good indication for ventriculotopex.
So coming
Remember,
on the same theme, when you have an aneurysm or a pelvic floor pain, do you have any experience of injecting Botox into the puborectalis?
yes.
Which
Good.
patients do you do
Yeah.
Botox?
Yes, you too. We
So
do,
I've
but
seen Ali Shafiq in Cairo actually dividing part of the puborectalis, and I'm scared of doing that.
me too. But, Ali can do what he wants. He's he can do what
So
he wants.
Ali did a workshop in Mumbai and he showed us how to divide it. And I was scared. This is my patient. Luckily, patient didn't have incontinence.
Yeah. You know that they cut the pubertalis and then reconstruct anterior. Also, Antonio shows something. Antonio Longo
Yeah,
shows something like that.
yeah.
I think I can repair the pubertalis macula. I can't think that I can cut but this is, we need to see the results. The problem that in this field we can say what we want, because there is no evidence at all of this time.
So we heard Steve Wexner saying in Mumbai some days ago that for a full thickness rectal prolapse, the answer in a fit patient is to do a resection rectopexy. Never do a ventral rectopexy. What are your comments? The Americans don't like VMR. They like resection rectopexies.
Isn't it? Like, who invented the resection rectopexy? Americans.
Frickman Goldberg.
Make
Yeah.
America great again. So we have to speak about
Make American colorectal surgery great again.
yes. I think that there is if I have a rectal prolapse, why I have to resect the sigma? I don't understand why.
Great. So I think another thing we have seen is we've published our data on STAR in the World Journal of Colorectal Surgery, and we find that about 3 to 4% of patients have tenesmus, an unexplained pain. What do you think is the cause of this tenesmus? And it sometimes persists for up to 6 months.
Because is if you involve in the staple line in the closure the pubertalis muscle.
Okay.
Sometimes
The problem
we have
any
we did more than 30 we remove a lot of scar of the tissue because of this kind of problem, especially posterior, because with some stapler they involve and you have not anymore able to have a good sliding of the rectum on the pubertalis muscle.
Another problem we have in India is we don't have these high volume staplers. We have to use two staplers and do a semi circumferential firing. So we normally use two staplers to resect the rectum. That is a problem we face. So we don't have these high volume staplers, the Chinese staplers in India.
You can I can ask to my friend that you know that I developed this kind of high volume stapler I drove
Sure.
for Chinese friends, and I think that is better, but I think that more or less is the same, is simpler, because it's a
Right.
stapler procedure, is not a double stapler procedure. You don't know if you have
Sure.
experience with CCS when we do for a pedo, was really difficult procedure. Why we can do easily, and we need to move from something that is easy to something Yes, yes.
I've noticed that I learned the POPs from Antonio, and it's slightly different operation from what you do. And he always combines a POP, like whatever we have done, we always do a star procedure with a POP. What are your comments on that?
I know that there are a lot of rumors about very good results, but very few data from literature about that. We saw that I heard that I do more than 1,000. Okay, show me the data. Show me the
Yeah.
data. You know that also, Shafiq, they call it
Yes.
the triple attack because
Yes. Yes.
I don't know, but is more or less the same. The POPs is more or less the same of Dubuisson lateral suspension. What I think that the indication is for cystocele, for urinary incontinence, for cystocele with anterior hysterocele. Is the problem is always the indication, like I show in the first slide. If you have star and pops and you do only star or pops, you don't need the other thing.
Right.
Okay, if you are able, we have to choose the right procedure to know all the procedure, but for this kind of problem of the patient. If I have only two operations, probably I can do, okay, this star or the other pops, the other pops and star. Okay, that's all.
I also noticed you didn't talk much about biofeedback. We don't operate our patients in India without giving them some sessions of biofeedback first. What is your comment to that?
I think that could be a good option. I think that is very difficult also for the physiotherapist to be able to manage to try to restore a normal physiology in an abnormal anatomy.
So in
I
a
think
pelvic floor
it's
clinic,
much more useful than if you do after the procedure.
so we've seen almost 30% of our patients we send for biofeedback who has an internal rectal prolapse don't come to surgery. They are happy with the results and they wait with dietary changes and laxatives and pelvic floor training. We have a lady physiotherapist who does only pelvic floor, and almost 30% we can avoid surgery.
But we needed to be able to select these patients. It's not the
Correct.
same patients that
Sure.
have to go to surgery. We have the
Sure.
patients that have to go to biofeedback, the patients that have to go to surgery, the patients that have to go to surgery and then biofeedback. This is our the challenge for the future, to be able to manage these kind of patients.
And when you suture the polypropylene mesh, is this a lightweight macroporous mesh or a normal Prolene mesh? On the vagina, on the suturing on the vagina.
Is a Prolene mesh, is a titanized Prolene mesh.
Okay. Wonderful.
Covered
We
by-
enjoyed your talk, Dr. Gabriel. It has been a pleasure to hear you. Would the other moderators or participants have any questions to put to Dr. Gabriel?
Great talk, sir. Dr. Gabriel. Dr. So just one question, how you manage incarcerated prolapse, the prolapse which is completely out, we cannot reduce it, there comes an emergency. So what is your advice to manage these cases?
Which cases? Sorry, I don't understand, Parkai.
The prolapse is completely out, the rectal prolapse, and you cannot reduce it. They are looking blue,
Altmaier procedure.
very much edematous.
Altmaier procedure, if the tissue are not good, there is a big edema. What I do is pull-through technique. I do the rectal resection. Then I don't do the anastomosis. I do the pull-through.
Yeah.
I put some stitches like for the pull-through for rectal cancer. And then after 7 to 10 days, I go and to finalize the anastomosis. This is a really useful. Remember about the pull-through technique that can help you when you can have problem. In high-risk patients, sometimes I do also as a first choice. I don't do the anastomosis, I do the pull-through, and after 10 days in local anesthesia, you can finalize, and the rate of dehiscence is close to 0.
Thank you. Very nice hearing to you, sir.
Any other questions from the other moderators?
Yeah, if I can ask something, Dr. Gabriel, fantastic talk. I mean, and it was very logically explained. So everything was quite convincing what you mentioned. One only thing that we don't do typically is that for vagina prolapse, you mentioned that you dissect fairly deep down between the bladder and the vagina. You went almost up to the tip of the trigone, and then you put a mesh which is lying sandwiched between the bladder and the vagina. So any concerns for us? The concerns would be, that will that mesh erode into the bladder? So we typically put it right at the apex of the vagina before opening up and completely dissecting up the bladder, the septum between the bladder and vagina. So have you had any incidences of mesh erosion into the bladder or any complications like that?
We have one. I remember one, but probably was the initial experience. And then we all know that for the mesh, that the problem of mesh is the transanal, transvaginal position of the mesh that give a lot of problem. For the abdomen, also the literature about ventral ectopexy, we know that we have less than 1% of mesh erosion, and this less of 1%, I just published this review, less than 1%, and in this less than 1%, we have only 0.4% of patients that need to be operated with major surgery. So I think that is a very small problem. And if you do properly the dissection, probably the level of the quantity of mesh erosion could be very, very low. But the risk is still present. Okay, we can say that there is. If you put a mesh, you must know that you can have problem. But we have to reduce. Is natural. If we don't need mesh, it could be better. But we all know that if we do only stitch surgery, probably in 4 years, 3 years, 3 days, I don't know, we will have the same problem.
So, what is the reason why you're using the titanium-coated polypropylene mesh as opposed to an uncoated polypropylene mesh? Is it to reduce this erosion
The
risk?
adherence, to reduce the adherence and the erosion. There is no evidence. But at the moment, what we can do is try to do our best to reduce this big problem.
So in fact, we want inflammation and fibrosis to pull the rectum up. And a titanized mesh is something we use intraperitoneally, not to get adhesions. And if you read the international consensus paper on VMR, there is no mention of titanized mesh. It's all macroporous lightweight polypropylene.
Is polypropylene, but is only coated by titanium mesh. Is only coated, but I don't live in. I don't like to live. I always cover that, not in the peritoneum. I try to always to cover and to put it extra peritoneally.
Right. And I think in VMR and when you're putting the mesh between the vagina and septum, it's relying more on the traction rather than the fibrosis. When we are used to do, when we are doing the posterior mesh rectopexy, it was the fibrosis which was really.
I don't think that's correct, Kalpesh. I think you rely on inflammation fibrosis even in the anterior compartment.
If you are relying on inflammation fibrosis for ventral mesh rectopexy, then that's going to erode into the rectum.
No, it doesn't. You read the international consensus paper on VMR. There's more than 2,000 cases. The mesh erosion is less than 1.5% world over. And using a normal proline mesh, not titanized proline.
Yeah, but really.
Anyway, it was a wonderful talk. I really enjoyed it. Lots to learn from this. And hand it back to you, Kalpesh.
Yeah, no, that's what as Gabriel was very rightly saying. that lots of rumors and less of long-term evidences in this field. So we still have, and that was very nicely put. I'll have to remember that particular statement, that lots of rumors and less of long-term evidence. That's great. Fantastic talk. I really enjoyed it. And if anybody has to add, otherwise, Radhip, you can wind it up.
So there are some questions from the audience.
Yeah. Oh, yes, please. Don't forget the audience.
So firstly, one of our viewers wants to ask how relevant is MR difficography for detecting multi-compartment prolapse? So would you advise it in all patients or in selected patients?
No, the fake MRI, we do in all patients the fake MRI before to do for internal rectal prolapse. For external rectal prolapse, I don't think that is useful.
Okay. No, so his question probably is that there is a rectal prolapse which is evident. Do we need a MRI to detect like a uterovaginal descent also?
No. If it is evident, if you have external rectal prolapse, it's not useful to have you can do, but it's not. I don't know which could be the information that can change in your mind what you are going to do.
Right. So another question, most of these patients obviously have constipation, the obstructive defecation syndrome. So if a patient comes with prolapse and incontinence, is that like a red flag sign? Or should we look for something else in that case?
No, we have to hope that when you pull up the rectum and you do biofeedback after, they can restore something. This is the hope that we have. But usually we don't do at the same time nothing more. Sometimes if we have a big rectal prolapse with weak pelvic floor, we try to do Altmaier procedure and to close to do or a post-anal repair or a total pelvic floor repair. But if we have a patulous anus, we can't do anything. I have no answer about patulous anus, and all my recurrence are due to the patulous anus. Because if you see the door that is open, everybody wants to go to see, and after you go out, if I have a door, and if I have the door open, probably I go first time, second time, the third time I go out.
Yeah.
This is a big problem, but I have no answer about the patulous anus.
Right. So there's another question. What is the alternative surgical option if recurrence occurs after pop star?
Recurrence of symptom or recurrence, anatomical recurrence? Anatomical recurrence probably is better to do a ventral rectopexy that is stronger, because you can use the promontory to use the same mesh, to cut the mesh laterally, and to use the same mesh to attach the mesh to the another mesh, and to suspend the promontory, because the promontory is stronger than abdominal wall.
Right.
For star, you can do nothing because you reset.
I get it. Yeah. So I joined the others in conveying my appreciation for the lecture you had given. It really covered everything. In fact, I'll have to watch this again a couple of times to get my concepts more clear. So
Okay.
for everybody else, our viewers, these videos will be available on the Amasi website, like all other online CMEs are available there after a week or 10 days of the broadcast. So you can view them again over there. Any other questions or comments, or we can close here?
It's 9:15. I think you can close it.
I want to thank you for this fantastic opportunity. I hope to have the opportunity in the next future to meet you all over in the world or in India, and so we can share the experience, because only to sharing the experience, and we have always to learn from the other experience. We have always to respect the experience of the others, and the more we discuss about this problem, the more will be the possibility to have a response to these difficult problems. Okay.
Right, sir. We
Thank
hope
you
to
very
see
much.
you. Bye. Thank you so much.
Thank you. And I also thank the moderators, Dr. Roy Patankar, Dr. Pankaj, Dr. Prakash, he's probably disconnected, and Dr. Jayanta, chairperson for this event. I will be amiss if I don't thank Meryl for their help in holding this webcast. So we have a few upcoming events in this month, which if they just show it, we'll talk about them also. The next month online CME will be by Heather Bogart, who will be talking about ventral hernia emergencies. Heather Bogart is from South Africa, a well-known surgeon in her own right. And Ayaz, could you show the slides, please? Ayaz?
Sorry, I have to go.
Yes, Dr. Gabriel. Thank you very much. Thank you.
Bye.
Thank you.
Bye.
And we have our flagship AmasiCon in August, the last week of August. You can make your bookings and be ready with them. I will talk about this. We move on to the next one. The MMAS programs at Hyderabad, which is on HPB at the KIMS Hospital, Kondapur, which will be held on starting on the January 30th. The MMAS hernia, Mastery of Minimal Access Surgery in hernia at Ahmedabad on the 6th of February. And the FMAS program, the 121st at IGIMS Patna, again on the 30th of January. So we have a number of programs in different parts of India. You can choose the one which is nearest to you or most suited to you. Next, please. And the next gen program, which is targeted more towards the postgraduate residents in various colleges. We have one at BJMC on the 10th. We have another at BJMC on the 14th. And we have at YCM Hospital on the 15th of February. Thank you. And naturally, our flagship AmasiCon in August, which I've already talked about, which is being held at the Biswa Bangla Exhibition Convention Center at Kolkata. So thank you very much for being part of the online CME. We really enjoyed it. I hope you also did. And I end with a Happy New Year to all of you. Thank you very much.
Thank you.
What was a visionary dream has now blossomed into the realization of a globally renowned medical device powerhouse. What evolved from a modest beginning now operate one of the most cutting-edge facilities in healthcare. What once was a single venture has now proliferated into a presence in 6 distinct domains. What began as a modest collection of products has flourished into a portfolio of over 200 diverse products. What was conceived in one country now operates through more than 150 nations. What started with a few inspired individuals has burgeoned into a global team of over 10,000 plus dedicated medtech professionals and underwent an evolution, experiencing substantial growth to emerge as a dedicated brand poised to address the healthcare needs of this world. All of this made possible through achieving comprehensive excellence in all domains. By embracing modern innovations that enable to win the hearts of healthcare providers and patients across the globe. The progressive transformation of the infrastructure has seamlessly mirrored the pace of technological advancements, culminating in an unparalleled achievement of elevated output and precision in production, setting an extraordinary standard within its niche. Welcome to Merrill Endosurgery, your one-stop surgical solution empowering excellence across oncology, bariatric, thoracic, gynecology, urology, gastroenterology with innovative and reliable instruments. From precision cutting tools to advanced energy devices, we deliver comprehensive solutions for modern surgical needs, ensuring safety, efficiency, and superior patient outcomes. Introducing Myras, range of stapling products. Powered endoscopic linear cutter. Endoscopic linear cutter. Linear stapler. Linear cutter. Circular stapler. Hemorrhoid stapler. Monic trocars. Eliaro trocars. Eliaro bladeless trocars. Introducing Merrill hernia portfolio. ITAC A, Absimesh, Merigro Mesh, Philiprop Mesh, Philiprop Mesh Soft, Marinium Mesh, Profound N, Profound A, Mesic Energy Device, Mesic Compact Ultrasonic, Mesic Laser, Mesic Ultrasonic. At Merrill, we don't just innovate, we empower. Together, let's create more to life. What was a visionary dream has now blossomed into the realization of a globally renowned medical device powerhouse. What evolved from a modest beginning now operate one of the most cutting-edge facilities in healthcare. What once was a single venture has now proliferated into a presence in 6 distinct domains. What began as a modest collection of products has flourished into a portfolio of over 200 diverse products. What was conceived in one country now operates through more than 150 nations. What started with a few inspired individuals has burgeoned into a global team of over 10,000 plus dedicated medtech professionals and underwent an evolution, experiencing substantial growth to emerge as a dedicated brand poised to address the healthcare needs of this world. All of this made possible through achieving comprehensive excellence in all domains. By embracing modern innovations that enable to win the hearts of healthcare providers and patients across the globe. The progressive transformation of the infrastructure has seamlessly mirrored the pace of technological advancements, culminating in an unparalleled achievement of elevated output and precision in production, setting an extraordinary standard within its niche. Welcome to Merrill Endosurgery, your one-stop surgical solution empowering excellence across oncology, bariatric, thoracic, gynecology, urology, gastroenterology with innovative and reliable instruments. From precision cutting tools to advanced energy devices, we deliver comprehensive solutions for modern surgical needs, ensuring safety, efficiency, and superior patient outcomes. Introducing Myris, range of stapling products. Powered endoscopic linear cutter. Endoscopic linear cutter. Linear stapler. Linear cutter. Circular stapler. Hemorrhoid stapler. Monic trocars. Eliaro trocars. Eliaro bladeless trocars. Introducing Merrill hernia portfolio. ITAC A. Absimesh. Merigro Mesh. Philiprop Mesh. Philiprop Mesh Soft. Marinium Mesh. Profound N. Profound A. Mesic Energy Device. Mesic Compact Ultrasonic. Mesic Laser. Mesic Ultrasonic. At Merrill, we don't just innovate, we empower. Together, let's create